Good afternoon and Assalamualaikum everyone. So my name is Faiza Muhammad Zaki and I'm from UKM, and I would like to thank the Body Imaging Committee for invitation of this to this webinar. I'm so honored to be part of this webinar. So my topic for today is kidney development and congenital malformation. So the lecture outline will cover some imaging for the assessment of the tract, especially in children. And we will have to discuss, unfortunately, the embryology of the kidney because we are talking about congenital here. And I will try to simplify on the types of the renal anomalies so that you will understand what are the type of how to tackle this kind of cases in your day-to-day basis. So about close to 1/3 of the congenital anomalies of the kidney and urinary bladder has been diagnosed prenatally, and therefore we as radiologists actually receive at the other end after delivery, and we are expected to assess and give some differential diagnosis related to these congenital anomalies. So it can be bilateral or unilateral. The fact about this congenital anomalies of the kidney is that close to 1/2 of the cases actually develop chronic kidney disease, and thus it requires some form of treatment, and later on may need a kidney replacement therapy. So we are talking about children here, and therefore we need to make sure that we are in the correct track so that the child will receive a good treatment. There has been increasing discussion on the relationship between human genetic syndrome with renal anomalies, especially whenever you are dealing with, I think one of the common primary diseases, which is the Backwoods vitamin syndrome. We know that they can be associated with tumor, and therefore we have to plan for the screening ultrasound for this patient group so that we do not miss any tumor later on. So before we proceed, I think it's good for us to discuss what are the main imaging modality that we use for renal anomaly assessment. And of course, ultrasound is the mainstay. It is the state of art in pediatric radiology. We normally use it using a curvilinear probe, but I can tell you that using a linear probe is also essential, especially in units, because you'll be able to have a good and very high resolution ultrasound assessment, especially related to how to differentiate between the cortex as well as medulla, and you'll be able to see if there's a small cyst related to a chronic obstruction later on. And this is an example of 8 years old. We know that the kidney is developing, and thus the normal renogram of the renal length is also important. Whereby fluoroscopy is involved radiation, but it's still considered as the gold standard in detection of the VOR, as it provides some functional information. And nowadays, MR urography has been increasingly done. It's very much effective because it does not cause any radiation. It provides some comprehensive cross-sectional morphological and also sometimes a functional information. However, it does cause some drawback whereby it needs sedation, and it's not readily available in all institutions because of the cost. In MRU, and especially in our center, we normally do that to assess the renal anomalies as well as the duplication anomaly, especially this one, because we want to determine is the exact ureteric cause, and therefore we know that whether the ureter is ectopic or or stenotic, and at the same time we can identify the renal parenchyma, as this renal parenchyma assessment could not be done by fluoroscopy. And in our institution also, we always interpret our imaging with nuclear medicine whenever it's available, because nuclear medicine study also provides some functional assessment, and like for example in this case, the patient had a hydronephrosis, and we know that the right kidney is not normal in terms of the renogram itself, because we see that the radionuclide maintains, it does not excrete compared to the one on the left side, and it's actually supported by the pre-void and post-void image, whereby we can actually see no excretion happen here in the case of a PUG obstruction. However, nuclear medicine actually involves some form of radiation, It has a slightly poor resolution compared to our anatomical conventional imaging, but each one of these can complement each other. Now, CT scan is only meant for assessment of the possible, suspected stone or renal masses. And for renal masses, do not do a multi-phase CT renal study, please. And CT scan is also can be done for assessment of trauma as well as the vascular assessment preoperatively, as we know that CT scan actually involve the radiation, and therefore I bold this because this is something that we have to take into consideration whenever we are dealing with this kind of cases. Now, I have to mention and have to discuss this in biology. I know it has been quite long away from us since your medical student year, but it really helps in terms of understanding the pathology of the renal anomalies. So our kidney is actually originated from a mesonephros fetal kidney, and it occurs around 6 weeks of gestation, whereby the urethral bud actually originates in the pelvis, and it divides from renal pelvis, and it becomes major calyx. At the same time, it starts to ascend caudocranially, and as it divides more, becoming a minor calyx, and it divides and it receives some supply from the aorta directly, as we know that's the renal artery supply, and then it's ascend and become more mature by 9 weeks. Okay, and the ureter almost always be at the same ipsilateral side, but during the ascent of the kidney, this kidney can actually migrate to the contralateral side, and it will provide some anomaly that I will discuss afterwards. So these are more or less the common phenotypic spectrum of renal anomalies. But I like to list it in terms of the types of the anomalies, so that we will understand and we know how to approach this renal anomaly. So it based on the renal formation or the morphology of the renal itself, the renal position or the renal numbers, whether it's present or not present, and the most importantly, and maybe the more common renal anomalies that we are seeing, is the development of the urinary collecting system. So in terms of the forms of the shape of the kidney, these are considered as the primarily a normal variant. Okay, so we can have a indentation at particularly in between the medulla, and that we call it as persistent fetal ovulation, that can persist up to adulthood. Like in this case, is actually in a 30 years old patient with renal calculi. So the thing about it, we can differentiate this as compared to a scarring, is that the scarring sometimes does not respect this location that is in between the medulla. It can go just above the medulla and cause reduction in the volume. Okay, so that's where we can differentiate between persistent fetal ovulation versus a renal scarring. And hypertrophic column of Bertin as well as dormitory hum can be mistaken or mimics a renal mass, but if you go very carefully, then you can actually see that the indentation of this column actually occurs in a specific location, as what we see here, and it can be differentiated with a renal mass. Whereas if you see no normal renal parenchyma, or maybe just a thin echogenic parenchyma, you don't see the ureter, but yet you see a multiple non-communicating cysts of varying sizes, then this is actually a multicystic dysplastic kidney, quite a common disease that can occur as a manifestation of neonatal abdominal mass, and it is commonly associated with contralateral urinary tract anomaly in about close to half of the cases, and most commonly is vesicoureteral reflux that can occur in about 20% of cases. Now, let us go to the abnormal migration, and this abnormal migration is basically because of the impairment in the migration, cephalic migration from the pelvis to the flank during the embryology. and thus it caused the pelvic kidney. And what we saw in the pelvic kidney is that you see a normal kidney but in a wrong location. This is in the kidney that located just posterior to the urinary bladder. And when you look at the area, the renal fossa that is supposed to have the kidney, and you do not see it, but yet you see the adrenal actually become more elongated. There's no more a V-shaped or Y-shaped adrenal, and we call that as the lying down adrenal sign, just because it does not have any support from the kidney inferior to that, and it's the renal fossa is being replaced, occupied by the bowel. So 10% of the cases can be bilateral, and this can be mistaken for horseshoe, like this one. This is a horseshoe kidney or a pancake kidney. We will discuss this later. So this is just an example of a pelvic kidney with a normal contralateral side. So pancake kidney is very, very rare, but whenever the kidney pole, upper and lower pole, completely fuse, then it creates a pancake kidney. And this particular anomaly can actually give rise to higher risk of hydronephrosis or pH obstruction and recurrent UTI, as we understand that the ureter is very much immature or incompetent, and thus it can cause all this. Now, a horseshoe kidney, on the other hand, is the most common upper GI congenital anomaly. So it occurs in about 1 in 400 cases, and what we see is not a complete fusion like the pancake kidney, but yet we only see a portion of the fusion most of the time, and almost always is at the lower pole of the kidney in about 90% of cases. This is what we call the isthmus of the horseshoe kidney. And we know whenever it goes transversely towards midline, it crosses the midline, and the vertebral body, the heart vertebral body is posterior to it, and this is the aorta, then it has a higher risk of developing abdominal trauma, especially in children, whereby they can have a bicycle handle trauma, and thus the horseshoe kidney can injure. Or there are reported cases whereby it has an increasing incidence of renal malignancy of Wilms tumor, especially in this kind of patients group. So the isthmus can be fibrous or parenchymal, and therefore MR is the best to assess that, but I believe on ultrasound we'll be able to see whether is it really a parenchymal by just putting a color Doppler. But if you want to make certain, then you can actually do an a MR, and you can see that the kidney can actually enhance. In this case, this patient actually had a complex hemorrhagic renal cyst here on the left side. Now, a cross-fused ectopia is whereby it is the kidney migrated to the contralateral side, and therefore it become two kidneys at one side, and you don't have a kidney on the other side. And most of the time, and about 90% of cases, fused. And like this one, you can see there's one kidney here, but another kidney that goes unseparated between the two, and therefore this is a cross-fused ectopia. So they have higher risk of obstruction, because you can imagine that the ureter is also being stretched, and it can be stenotic and being compressed by the adjacent structure as well. Okay, abnormal numbers, renal agenesis is the most common, and most of the time it will be incidental, but you have to remember that it can be associated with contralateral geo anomalies, especially the reflux or the pH obstruction. Whenever you do an ultrasound and you do not see any kidney at the expected location, like in this case the right kidney is not there, you can only see the adrenal. So have a look at the pelvis, whether are we dealing with a pelvic kidney instead. But if you don't see it, and you go to the contralateral side and see the the contralateral kidney, and whether is there any other kidney that goes inferior to that can give rise to a cross ectopia. But if you don't see that too, then definitely this is a renal agenesis. Okay, so if it's the bilaterality of it is rare, and it's known to be associated as the Porter sequence, patient will come with oligohydramnions, pulmonary hypoplasia, and limbs deformity. and most of the time they have a higher mortality because of this palming hypoplasia, and they have a typical portaphysis like this one. Okay, so this is a case of a 18 years old with amenorrhea, and and they want to exclude if there any female reproductive anomaly. So in the thing is, when we did the study, we also include the kidney visualization, and then we did not see any kidney on the right side. Okay, the left kidney is there, and when we look at the region of the pelvis, you realize that there is no uterus, but the lower vagina is present. So this is a Mayer-Rokitansky's Kerster-Horster syndrome, which is not that uncommon actually. And this is patient presented normally with primary amenorrhea with normal pubertal development. They have an absence of very hypoplastic uterus, and the upper vagina, two-thirds of the vagina is absent, and this is basically due to the Mullerian duct anomalies. And because of that, the external genitalia is normal, the ovary is there, and the patient is has a female karyotype. Okay, so always include a corner T2 or T1 in the assessment of any Mullerian duct anomalies, because we know that it can have association like this one. Okay, you do not want to miss that. Okay, so the anomalies of developing urinary collecting system normally occur during the 5th week of gestation, and as listed, we will discuss some of this because it's quite common. Before that, I just want to highlight that we normally describe our pelvic dilatation kidney using this UTD classification, because it's actually a standardized terminology, very unified. Our primary team understand it. And the thing is that it can actually be done antenatally as well as postnatally. You know what are the risks of this, and how do we go about afterwards. And normally we do this after 48 hours of life postnatally, because the first 48 hours of life we only do in patient with anorexia or patient that is suspected to have PUV, posterior uterine valve, because patient has oligohydramnions. But any other patient, we actually preserve, and then we do it after 48 hours. So they have this UTD P1, UTD P2. I need to have another lecture for me to discuss this, but just to show you, this is what we are doing. For P2, we have this more than 15 mm with a ureter abnormality. But if we have a parenchymal thickness abnormality, and anything about the parenchyma or the bladder abnormality, then we already classified it as a P3. So this is a day 3 of life boy presented with antenatal hydronephrosis. The right kidney is normal, but the left kidney is abnormal, very hydronephrotic. But you can see that it looks like a Mickey Mouse, with the big ears, and there's a sudden truncation at the region of the renal pelvis. This is the high resolution ultrasound, and basically showing the same thing, but this is how we measured the anteroposterior kidney diameter, and it is more than 15 mm in this case, and distally we do not see any dilatation of the distal ureter. So this is a typical presentation of pelvic ureteric junction obstruction, most commonly unilateral, but 1/3 of the cases can be bilateral, and about 40% of cases is associated with vascular compression at the level of where the truncated pelvic ureter dilatation is. It's rarely associated with there's rare incident of coexisting PUJ obstruction and VOJ obstruction at the same time in the ipsilateral ureter, but that can occur. But in this case, about 1.9% of cases. Now, this is a 9-month-old boy, had a pyeloplasty done at the age of 3 months, and what we did a follow-up ultrasound, and we see increasing dilatation of the renal pelvis on the right side, and it's actually even more than what we saw a month before this. And there is also dilatation of the distal ureter. Now, the kidney, the MAC3 actually showed that there is poor excretion that goes that represent in the right side, and even post-board we still see there is no excretion in the right kidney. So we're thinking, is this a recurrent PUJ obstruction? But why does the distal ureter also dilated then? So we did an MRU, and what we see is that yes, the upper system is dilated, and there is a narrowing at the PUJ region, but there's also stenosis at the distal one, and we also see some mild narrowing at the left side. Okay, so so this is patient actually had a recurrent PUJ obstruction and concomitant PUJ stenosis on the right side, which he falls in that 1.9% of case. Now, renal duplex renal system is a duplication abnormality that is quite common. But the complete duplication is less common, and the patient will also always be symptomatic. And we know the Weigert-Mayer's rule, whereby the upper moiety of the kidney ureter will actually insert more inferiorly and medially as compared to the lower moiety ureter. And this upper moiety ureter is more prone to get obstructed, okay, by the urethrosil, and it can be ectopic. But the lower moiety ureter is more prone to get reflux. Now, this is a 2-month-old boy with was referred to us, and because antenatally they noted there's a suprarenal cyst. So when we did the ultrasound, we saw that this is the kidney, and it looks like it's the kidney actually extend up to here, because the shape of the kidney does look like this, and we saw this so-called cystic lesion. And what we saw also is that there is a dilatation of the distal ureter behind the bladder. So from here we thought, okay, patient might have a duplex system, but the upper moiety is very abnormal. It looks like there's no parenchyma actually, and we do not see a normal configuration of the calyx or medulla even. Now we proceed with MCUG because the distal ureter is dilated, and we want to exclude any reflux. And on the cystogram, you do see a filling defect here that represents the urethrosil, and at the same time we do see a reflux that goes to this moiety, and this moiety is actually the lower moiety. Okay, it doesn't really show the drooping lily sign like a usual, because the upper moiety now is already shrunken, and therefore you don't have a mass effect that goes compressing on the lower moiety. And this is the MAC3. I think I can pass that because it doesn't actually show quite a significant obstruction, but we need to ascertain where is the distal ureter. So we did an MRU, and then what we see is that that's the urethrosil that we saw earlier on the cystogram, and that this is the lower moiety that is dilated, and it has reflux, and the upper moiety is the one that is the so-called suprarenal cystic lesion that they saw in the antenatal area, and it was actually confirmed on the intraoperative finding. So this is a 4-month-old girl, bilateral antenatal hydronephrosis. Similar findings that we saw in the earlier case. Bilateral upper moiety is dilated. The lower moiety on both sides looks more or less normal, but the distal ureter or even the proximal ureter is dilated and tortuous on both sides. Both sides had a very dilated vesico-ureteric junction. Okay, right side and left side. Now, the clinical question is, where does this distal ureter inserted? So we did an MRU, and what we can actually see that this is the lower moiety, which is normal, and the upper moieties on both sides is very abnormal and very tortuous, very dilated. You don't even see the shape of the normal kidney anymore, and that we also give contrast, and we can see that there is excretion that involving the lower moiety, but no excretion in the abnormal upper moiety. And this is the distal ureter that we can actually see. The distal ureter is inserted very, very low towards the urethra, and therefore the patient actually had an ectopic ureter. Okay, so this child actually had quite a rare bilateral and even intraoperatively noted another small non-functioning ureter on both sides, bilateral urethral triplication with bilateral complete duplex kidney. Okay, so this is a 4-month-old boy come to us with for one episode of atypical UTI. The key is atypical UTI, and you see on the left kidney is dilated, and the proximal ureter is also dilated compared to what we saw on the PUJ obstruction earlier. And then we see the distal ureter is also dilated. Look at where the wall looks thickened. Same goes to the bladder as well. Now we proceeded with MCUG because we are quite certain that this looks like a vesicular-ureteric reflux, and true enough that you can actually see the reflux on the left side with an abnormal or dilated and mildly tortuous ureter. So we classify it as grade 4 VUR. So reflux is quite common in children with UTI. It can occur up to 40% of the cases. Voiding cystoureterogram is the key diagnostic modality. However, some centers will do a radionuclide cystogram or echo-enhanced urosonography. This is especially true in the European country. And whenever you have a case with hydronephrosis with ipsilateral dilated distal ureter, always exclude the vesicular-ureteric reflux. And the grading of this VUR is very helpful in determining the planning of the patient management, because normally the grade 1, 2 will have a medical treatment, grade 3, 4 and 5 will have a KIV surgical treatment. Now this is a child with recurrent UTI. So you can see that the right kidney and in 2013 is small compared to the left kidney, and the normal reference for the age at that time is 6.15, which is only 4.3. And then the patient had a MCUG done, and you can actually see there's a reflux, and we noted that this is a grade 3 VUR with a scarred right kidney. This is what we saw on the MAC3. And then 4 years down the line, you can see that the right kidney is still growing, but to a lesser extent, and is smaller because of the effect of the scarred kidney. Okay, and thank God the left kidney is still normal. So always compare the renal lung with nomogram. We have Rosenbaum from the year 1984 as our reference, and recently we also had a sonographic nomogram in our population, and we noticed that our population kidneys are slightly lower as compared to what Rosenbaum has identified earlier. This is especially true in a younger age group. Okay, so this is a 7-month-old atypical UTI. So you can see that this patient had quite a small kidney on both sides with dilated central calyx, and there's bilateral dilatation of the distal ureter on both sides, and even the mid ureter is also dilated. Okay, but one thing about this case is that if you notice the left kidney, the configuration is a bit odd. So we bring our probe a bit more towards the midline, and you can see that, and the orientation of the renal pelvis is also more anterior located. And what we notice is that the patient actually has a horseshoe kidney, because there is a parenchyma that crossing the midline. And then this is the MCUG, which actually had a bilateral vesicular-ureteric reflux. And look at the orientation of the pelvis, which is more anteriorly located. And this is how it looks like on the MRU. And you can appreciate that with a dilated distal ureter as what we saw on the ultrasound. Okay. Alright, so this is a newborn. So we did this case, I think less than 48 hours, because the child is anuric. Okay, so we had an oligohydramnion, pulmonary hypoplasia. So we went up and then did an ultrasound in the NICU, and what we saw is that a very echogenic with very abnormal parenchyma with multiple cysts in both kidneys, right and left. Okay, and what we saw as well, that the right ureter and the left ureter is so dilated down to the distal ureter, and the unibladder is also thickened. Okay, and this is the time when we have to do an ultrasound and have to exclude what is happening in the posterior urethra. So this is the rectum, that's the urinary bladder, and we put our cursor, our probe at the symphysis pubis because that is at a region of unossified bone, and we'll be able to go and then assess the posterior urethra, and it looks dilated. Okay, so this is a case of posterior urethral valve. Most common cause of urethral obstruction in male: bilateral hydronephrosis, hydroureter, and thick wall bladder plus oligohydramnion. So it's equivalent to PUV. So postnatally, we always confirm that with MCUG. We can see that the bladder is very trabeculated, and then there is also a sudden truncation of the dilated posterior urethra compared to the anterior urethra. Okay, so always suspect whenever you see this bilateral hydrouretronephrosis plus a thick wall bladder and the child is oligohydramnios, because the prognosis is very poor and they can have an early renal failure and also non-functioning kidney. So just to show you the milder form of PUV, how do we look like? It's very thin transverse filling defect. That's what PUV. Okay, so this is my last case. This child in 2005, a long time ago, you can see that the left kidney and also the right kidney is dilated. The ureter is also dilated. Even the distal ureter is also dilated. So we did MCUG because we thought this could be something to do with the reflux, but the bladder is not trabeculated, so may not be a PUV, but we still proceed with it. Yes, there's no PUV on the MCUG, there's no reflux either. So we thought, oh, maybe there is a stenosis at both of the VUJ. When we did a retrograde pyelogram, noted that the distal ureter is dilated, so that means really the ureter is abnormal, but there's not much of stenosis because you can actually see some trickle of contrast that goes down. So but the DTPA at that time actually showed a progressive obstruction. So but later on in 2017, the child actually demonstrates some evidence of trabeculated bladder. So this is a primary megaureter. It can be obstructed or non-obstructed. Okay, in our case it's obstructed, and it is actually in a cases postnatally, whenever you investigated, you cannot find any evidence to suggest a reflux. You have excluded the reflux, you have excluded bladder outlet obstruction in a bilateral hydrouretronephrosis. Then a diuretic renogram may be helpful to see evidence of obstruction at the VUJ, but eventually when we have excluded this, then we can come to this diagnosis. Okay, so on the other hand, this is one particular syndrome that is associated with a dramatic dilatation of the collecting system, but it has a component of a laxity of the abdominal musculature and also a cryptokardism. So you don't see, the testis is undescended. So we normally being diagnosed that on the fetal MRI, and it actually showed a grossly dilated entire collecting system, but the wall is large, not thickened, the wall of the bladder not thickened, and you have a bilateral hydroureter and hydronephrosis. Parenchyma can be dysplastic, the entire urethra is also dilated, and the abdominal wall is lax. So all this actually points towards prune belly syndrome. Now, so the take-home message is that the geo anomaly in children is well explained by embryology. Always go back to embryology for you to understand the pathology of this. And of course, ultrasound, as I showed, I hope I have enough to show evidence that ultrasound is the first line of imaging modality, and sometimes it can be diagnostic too, okay? And there is always an association of other related geo or extra-geo abnormalities, so beware of that. Always search for secondary problem, okay? Don't just stop to PUJ obstruction and not seeing others, okay? So, and always use a common reporting template, utility classification that eventually will help our clinician in the patient management and follow-up. So with that, I thank you. Thank you for listening.